This is Ann Chensky, Project Coordinator for the Great Lakes Mental Health and Prevention Technology Transfer Centers, and your host for today's Great Lakes ATTC podcast. The Great Lakes ATTC podcast brings interviews and insights to the addiction treatment and recovery services field in the Great Lakes region and beyond. Today's podcast is the fourth and final session in our premier series focus on recovery and substance use disorders. Please welcome today's guest, Dr. Michael Flaherty. Dr. Flaherty is a clinical psychologist with over 30 years of experience in addiction, overdose prevention, workforce development, and the science of recovery. In 1999, he founded the Institute for Research, Education, and Training in Addiction. He has previously served as the Vice President for Behavioral Care at the St. Francis Health System, Director of the Division of Psychiatric and Addictive Services at the St. Francis Health System, and co-founder and first board member of the University of Pittsburgh Medical Center's local nonprofit managed behavioral care company, Community Care. Currently, he focuses on his clinical practice and assisting communities to develop and implement ROS, recovery-oriented systems of care. Thank you for joining us today, Dr. Flaherty.
Oh, you're very welcome. Glad to be here.
As a starting point, could you tell our audience what is ROS?
Well, in really everyday layman language, a ROS is a recovery-oriented system of care that speaks of the values and choices of a community. It's a community-up effort to address behavioral health, mental health, substance use in the local community, led by community members, many of whom themselves had that experience, or are called peers. But it's a value of what that community wants to do with the resources and the science and practice that's available to it in that community. It is not a treatment network or an agency per se, but it is, instead is an express set of values that are guided usually by the county or leadership in the community, perhaps a health center, that builds on not only the addressing of the illnesses, but building the strengths and the resiliencies in individuals, families, and communities. Measures that as it goes so that community wellness is achieved over time.
Great, thank you. Does ROS span both mental health and substance use?
Oh, indeed it does. And it also reforms, if you will, brings the medical model itself, which we all use, into the 21st century. But mental health is equal partner as substance use in a recovery-oriented system of care. Same measures are often used, different approaches, though I would say there are different languaging, to patient participation, different ways that they do participate, and the principles are very similar for mental health and substance use recovery. However, there are some distinct differences. For example, in mental health recovery, there's a real effort to build self-direction and individualized care. In substance use, those are important, but the idea of having knowledge, medical intervention, and peer supports and community oversight is a bit different than what it would be, say, to empower the person to design their own care. So it's a bit different at the principal level, but absolutely it covers both mental health and substance use.
Thank you. Is ROS being adopted by state, counties, providers, and those in recovery?
Yes, it is. It's interesting that ROS began its reinvigoration or its reinitiation through the ATTCs, not quite 20 years ago, about 15. And since then, through efforts of SAMHSA, the ATTCs themselves, and particular ATTCs like LATSI and at the time Northeast, ROS has taken off now, where at least we know that 51 states are using it or components of it at different levels, depending on how they implement. Some states are going completely statewide with it, and we know that 14 countries internationally are using the principles and guidance of recovery-focused care within the guidelines of a ROS in their implementation of treatment in those countries. So it's sort of been, if you will, under the surface a little bit with the overdose epidemic that we are experiencing in the country. But it is there, it is thriving under the surface, and now many papers in states and federal government are referring to how ROS affects and could diminish even overdose itself. So ROS is growing and is well, but under the surface, given the current epidemic and crisis.
Hancock County, Ohio has a successful ROS project, and we understand that you were involved in helping to build it. Could you tell us a bit about the project and how you contributed to establishing the ROS project in Hancock County?
I'll be glad to. Well, about 5 years ago, and that takes time, Hancock County had decided in Ohio that it wanted to transform its system of care, and that's one of the ways you implement a ROS. You can do it, just in an agency. You can do it through a small system of care, or you can do it through a whole system. And they decided the whole system. So 5 years later, they have been working arduously on putting ROS measures in, earlier screening, stronger prevention, all based on what made people well in their community. That's what makes ROS so pertinent. The data it derives to design the system locally comes from local experience. So ROS built those, and over those 5 years, it has more than tripled the amount of people getting help. It has not increased the cost of treatment, and it has now reported, despite the epidemic in opiates, reduced overdose deaths by about 9% in that community, which is, by the way, in the belly of the beast, so to speak. It's in the heart of where the opiate epidemic exists in rural Ohio and the areas of the hillbilly elegy. So they're rather proud of it. They see the long-term effects of a ROS, and they've seen things like increased access to care. They've seen great increases in numbers of people getting an adequate dose of care, which monitors the 90 days or more of treatment and how many are getting continuous care to that level. And it follows up and measures people at periods of recovery at 6 months, 9 months, and 1 year. And they're seeing even better outcomes there. So their efforts to address the opiate epidemic are returning to them insight into long-term and sustainable recovery in the population that is making that happen. They're still in the belly of the beast, though, with the epidemic and the numbers of overdose going up and up in the whole of Ohio itself. Very effective program, though.
Good. We talked a little bit about this, but where is ROS today? And from your perspective, is ROS an American shift in the approach to substance use?
Well, it's a great question, and the last part of it I'll go to first. ROS is probably the oldest treatment philosophy we have to address substance use and mental health both, because the premise of ROS is recovery. The synonym for ROS is focus on recovery or recovery-focused care, which puts the person, of course, in the center of it. And this is the oldest purpose for why we do what we do, which is a question I think we all need to ask from time to time. So is it recovery, or is it, say, topical care or maintenance or episodic care, where a person gets so much and then gets sent home and has a reoccurrence, which occurs so often in the substance use field. 80% will have a reoccurrence within the first 90 days of treatment, unless they're involved in a ROS. So ROS, the old philosophy, has now been reinvigorated into the best science and practice today, saying that we will measure our success not by necessarily the number of people getting well or into treatment, but over time, that this illness, which is often chronic in nature, has to be monitored, and people need to be sustained in treatment, and that knowledge needs to return back to each community so that the community can build the stickiness, if you will, or the access points where the person can achieve an opportunity for recovery. And that's the mantra of ROSC. Every episode of care, every event of care must be part of an opportunity for recovery. And that in the back of mind is what's so important in a rather fragmented and disconnected system of care.
Great. It does sound like a lot of the things that you've talked about, ROSC really does make a difference.
Oh, yeah. I mean, studies of, and there are great resources, by the way, for those that are interested. ROS, to me, in whatever outcome you have at any agency, and this is a generalization that I've noticed in my work now in well over 50 or 48 states, that the outcomes are improved by about 15% on whatever level if ROS is used. So let's say that we know that 20% of the people are getting a 90-day continuum of care in a local community. Add ROS to that, such as a peer support, you're going to get that figure easily up to 70 or 80%. So, but each of those services, say through adding peer support, through parent education, family involvement, values of recovery integrated into general practice, et cetera, will improve the outcomes and reduce the cost, which was found in Connecticut by Dr. Tom Kirk, and South Carolina, and in Ohio, and other places, because the episodes of care are reduced and the levels of severity are made available to those who truly need that, and everyone else is hopefully treated at a level of care appropriate to their having that opportunity for recovery. So I just use a generalized 15% improvement. I have some data to back that up, but it probably could be higher in some areas and lower depending on the population we're talking about.
Dr. Flaherty, do you have any resources that people could go to get more information about how to start a ROSC or the effects of a ROSC?
Sure. Now, how to start a ROSC, I would suggest that if they send me an email personally, I could send them a little study guide we've prepared. The effects of ROSC, there are three really excellent sources. One for the Ohio project itself, Hancock County. It was reviewed in the Journal of Psychiatric Services in October 2018, and there's a write-up there, and I can also send it to people if they're interested. And there are two key websites, WilliamWhitePapers.com, WilliamWhitePapers.com, and RecoveryAnswers.org. That's Dr. John Kelly's site at Harvard University, where hundreds of research articles on ROSC exist between William White Papers and RecoveryAnswers.org.
Great. That's really good information. Thank you.
You're welcome.
Thanks again for joining us today, Dr. Flaherty, and thanks to all of our podcast listeners. The title of our podcast theme song is Home, an original piece for guitar composed and performed by Steve Waugh.